Hey guys, welcome back to the implementation track where we're teaching you and giving you a lot of information that you can actually put directly into practice. I'm your host here, Dr. Emily Seitz, and I want to remind you guys, if you guys are just coming back in, a couple of key things that I've noticed as we've been kind of bopping around the site. The first thing is, if you are curious if your track or the course that you're watching is CE approved, you can look up to the left of the viewer box and it will actually say at the very top whether or not it is CE approved. Regardless, there's so much good information that you're taking away from the implementation track, including this next presentation by Dr. Fulmer about updates in AMD.
Thanks so much, Dr. Seitz. I'm really excited to be here today. Eyes on 2021 was amazing. I'm so excited to be part of Eyes on 2022. I hope y'all are enjoying it so far. I know you've got a whole weekend packed full of stuff. So we're going to dive in a little bit into macular degeneration today and talk a little bit about some of the stuff that we may already know, but a lot about the things that are coming down the pipeline and what's gonna happen from there. So just a little bit about myself. I am Dr. Patricia Fulmer, as Emily said. I'm out of Huntsville, Alabama. I was in the 2012 class at UAB, and I completed a residency in ocular disease and primary care out in Amarillo at their VA. Saw about 2,000 patients that year, so whirlwind, learned a lot, and just kind of reiterated that passion for disease care. When I moved back home, I took over a center director position at Vision America of Huntsville, which is a referral center dedicated strictly to disease management. So no primary care, lots of glaucoma, lots of macular degeneration that we'll be talking about today, just a lot of everything there. And then kind of missed some of the primary care and patient interactions. So I jumped back into private practice with a group, and then in 2020 decided that my heart was leading me to open my own practice. So here we are almost a year in, and looking good, enjoying the craziness that is private practice, and loving it each day. So before we go too much further, here are my financial disclosures. None of them conflict with today's lecture, but I do consult and speak for Allergan, Zeiss, and Cynosure. And since nobody enjoys financials, there's our little fur babies, because why not? So diving into what we are actually going to be doing today, we're going to kind of run through it all. We're going to start with defining age-related macular degeneration, which is, for the purposes of this lecture, going to be abbreviated as AMD. And then we're going to review the history and the importance of AMD. After that, we'll kind of go through the epidemiology and the risk factors, look at the disease processes, different stages of macular degeneration, and then understand the diagnostics, where we've come from, where we're going in that, and then do the same for treatments. So let's dive right in. How does Oxford define macular degeneration? So macular degeneration is a degenerative condition affecting the central part of the retina, or the macula, and resulting in distortion or loss of central vision. It occurs especially in older adults, in which case it's called age-related macular degeneration, which is what we will be focusing on today. As you can see in the photo, patients typically reserve their peripheral vision just fine, but their central vision is what is affected. So when was macular degeneration actually discovered? It goes back pretty far, believe it or not, back to 300 BC. But the earliest descriptions were really recorded around 1850, and the names have changed numerous times throughout the year, kind of dependent upon what we knew about the condition and the disease process and what clinicians were perceiving when they were examining their patients. So looking here, we won't go through all of them, I promise, but you can kind of see, starting 1855, initially it was called degeneration of the choriocapillaris and pigment layer and senile amblyopia. So basically, it was thought that just because you were getting older that you developed amblyopia. So there was no real reason that you were losing vision except that you were just aging. Over time, we've of course learned that wasn't true, that there are actual processes occurring and things that we can control or prevent. So going through many years, almost every year, there was a different change. By 1920, they were referring to macular degeneration processes as tumors in the macular region. My guess is probably because of the drusen. They probably perceived those as a form of the tumor. By 1923, we had senile exudative macular retinitis. So we're getting a little closer. And then by 67, we're starting to get a few different variations, with 1944 being the first time we hear senile macular degeneration. Now, in reports, they say that not only did patients freak out about the idea of having macular degeneration, but they didn't really love being called senile either. So clinicians dropped that name. And by 1969, we had age-determined macular degeneration. And then finally, age-related macular degeneration in 1987. 1995 was actually the first time that we heard wet and dry AMD, or early and late stage AMD. And the names are actually still evolving, even though age-related macular degeneration, or AMD, has kind of stuck for the majority of clinicians these days. AMD is a leading cause of blindness in the United States. It's also true worldwide, but we're going to focus a little more on the demographics here at home. Looking at that a little further, the causes of visual impairment, top 5 for each race, from whites to African Americans to Hispanics, age-related macular degeneration is in the top 5 for each of those, as you can see. Causes of legal blindness, on the other hand, still in the top 5. Definitely the number 1 for non-Hispanic whites in the US, with 46.6% of people that become legally blind having age-related macular degeneration. It is 3 times more prevalent than glaucoma, even though sometimes in clinic we may feel like we see glaucoma more. But if you combine glaucoma and diabetic retinopathy, it's actually still more common than both of those together. So who gets macular degeneration? Pretty easy answer there, everybody, but it sways significantly more to older Caucasian people, with Blacks and Hispanics and other races coming in with at least 2% as we age, more like 1 to 0.5% in the younger populations. But you can see here that it is significantly more common in Caucasian people. Of the Caucasian race, 2.5% develop AMD over time, with 2.1% of the entire population developing it, and 0.9% of Black, Hispanics, and others. In 2010, they looked at how that fell throughout all of the cases of macular degeneration and found that 89% of those cases were in white patients, with 4% being in Black, 4% being in Hispanic, and 3% being in other. And then they found that women do tend to get it a little bit more than men, with 65% women, 35% men. But the reasoning here is that women's life expectancy is actually a little bit longer. And of course, it being an age-related condition, the longer you live, the more risk that you have to develop it. Looking at prevalence over time, we know that based on an aging population, macular degeneration cases are going to continue to rise over the next few decades. Looking back into 2000 to 2010, there was an increase of from 1.7 million people to 2.07 million people just in those 10 years. And we expect that when the 2020 data comes out, that's going to be even higher. Projecting that out into time, if you look at 2050, we're expecting that trend to continue upwards, with Caucasians still leading the way there. However, if you notice, Hispanics actually are gaining at a faster rate, just still at a significantly lower total. They actually had a 6-fold projection over time, whereas Caucasians were a slightly less rate than that. So what are the risk factors of macular degeneration? The number 1 factor that we all know, and I know we preach every single day in our clinics, is smoking. It does raise risk by 3 times and is one of the most controllable factors that our patients can easily adapt or change should they find themselves dealing with this, or if they were really just wanting to prevent it, which we all hope that they do. Age is another huge factor. As we saw in the previous demographic graphs, it definitely increases over time. So with age, if you're over 50 years old, you are at risk for macular degeneration. Race, again, we talked about Caucasian patients being the highest risk. Family history, 50% chance of developing AMD if you have a relative who also has macular degeneration. Now, this is mostly for your direct relatives, so it's going to be mother, father, sister, brother, grandparents, but any family history raises the risk somewhat, with the greatest being higher, depending on how close the relative is to you. Not only does it raise your risk of getting macular degeneration, but it also goes up for the chance of advancement. So we see more severe stage, we see more progression in patients that have a family history, not just staying at those early and mild cases. Other factors include sun exposure, weight, diet, especially high in saturated fats. So it's going to be your dairies, your red meats, those sort of things. So people need to really try to adapt that best they can. Hypertension, cardiovascular disease, hypercholesterolemia, and diabetes. So pretty much anything that raises inflammation in the body or causes breakdown throughout the body also causes breakdown in the macula. Genetics has been a big topic in macular degeneration over time. Over the last decade, we've had a lot of discussion about whether or not genetic testing is worth it, whether or not our patients should do it, does it change their treatment? And really the answer is still kind of unclear. The proportion of heritability that's explained by known genetic risk variants is approximately 50%. So that means that we can identify about half of the genes and the markers that are causing macular degeneration, but we can't identify the other half yet. So that means that while testing is available, the clinical application is still kind of uncertain. There is typically increased compliance, though, in patients that want to get tested. So when they take the effort to go get tested, they find out that they do have those markers. It usually increases their chances of listening and doing what we ask them to do, being compliant with their treatments and preventative measures. And it also gives us the ability to have a little more insight into how closely we should monitor. So it certainly doesn't hurt, but it's not necessarily guaranteed at this point to be a useful tool for all of our patients. So let's dive a little bit into what actually happens in macular degeneration. In a non-diseased or normal patient, we have photoreceptors lying nicely and organized over the RPE, which sits on Bruch's membrane that's healthy, not swollen, and then our choroid with our choriocapillaris. In early AMD, we start to see a thickening of that Bruch's membrane, which leads eventually to cell damage over time. Once we get into the intermediate stages, we're starting to see prominent drusen, and the actual functionality of Bruch's membrane is starting to become compromised. As it progresses, late dry macular degeneration has large drusen, very, very disruptive drusen. So they're going to affect the RPE, they're going to affect the photoreceptor layer, and they provide a true structural breakdown of Bruch's membrane, which usually means that there's also associated vision loss. And eventually late wet macular degeneration, which leads to a breakdown not only in Bruch's membrane, but breaking through that surface with our choriocapillaris vessels into the retina itself. This progression has been assigned into actual categories through the AREDS study. There's a couple of other studies that have also assigned categories, but they all go basically on the number of drusen and the size of those drusen or the size of the findings. So for the purposes of today's lecture, we're going to focus on the AREDS classifications, but you can use the other ones if you prefer. So stage one is basically a normal or aged normal person, meaning that they have few 5 to 15 small, less than 63 microns, or no drusen without pigment changes. So basically a couple of little things that's not affecting vision. They're not going to have any problems down the line. This is still considered aged normal or stage 1. Once we get into stage 2, we consider that early macular degeneration. We have several small drusen, few intermediate sized drusen, so somewhere between 63 and 124 microns, and or pigment changes in one or both eyes. So as you can see in these pictures, the top picture is going to illustrate a bunch of small drusen. So we have several small drusen basically congregating in that macular area and allowing for eventual RPE changes that may affect vision. In the lower picture, while we don't have as many, we have larger ones. So in this case, they're intermediate sized, which makes them fall into early AMD. As we get into stage 3, we're looking at intermediate macular degeneration, which means extensive, 20 or more, hard or without any soft drusen. So we've got intermediate sized drusen, we can have a large sized drusen, or you can start to get geographic atrophy. But if you do, those aren't going to be in the central fovea. They're not going to be affecting vision quite yet. This is illustrated in the top picture here. So we have large drusen, we have coalescing drusen, quite a few soft, large intermediate drusen, but off to the side, not in the middle of the fovea, we also have geographic atrophy, excuse me. In the bottom picture though, no atrophy here, but we do have a lot of large and coalescing drusen right in the middle of the fovea that's gonna cause vision disruption at this point. In stage 4, it's interesting because AREDS does not allow for a bilateral stage 4. And the reason for that is because once that patient reaches a bilateral advanced stage, AREDS treatments are no longer effective. So by definition, stage 4 is an advanced unilateral macular degeneration. So that's going to be advanced dry form, meaning geographic atrophy that involves the central macula, or exudative form with choroidal neovascularization in one eye. So the center picture here demonstrates a stage 2. That could be paired with either one, top or bottom of the picture. So we could have geographic atrophy with the center picture, or we could have neovascularization with the center picture, and that still be considered stage 4. As long as it's unilateral, then it's not going to be moved on to the bilateral advanced stage, and we're not going to have to abandon AREDS treatments at that point. So there's still at least one eye that the supplements will help. They did break that down a little bit further. Stage 4A actually describes an eye that has one eye either with geographic atrophy or neovascularization, but the other eye in stage 1, 2, or 3. Stage 4B is a patient who has less than 20/30 vision in their better eye and geographic atrophy or cortical neovascularization in the other eye. Again, can't be in both. Bilateral advanced macular degeneration, on the other hand, is going to have geographic atrophy or a CNVM in both eyes. It can be either one. You could have wet in one, dry in the other, dry in both, or wet in both. But in these cases, AREDS does not apply at that point, and so that's why they were not staged within that study. Dry AMD definitely makes up a majority of our cases, with about 80% of our cases actually becoming dry. The vision loss in those cases are usually gradual. However, wet AMD is responsible for the majority of true vision loss. It's usually the most severe loss and typically happens the fastest. So how do we diagnose AMD? A lot of our patients with early stage, especially stage 1, stage 2, really aren't going to come in with many symptoms. They're not going to tell you that they have a problem. But the ones that do, the ones that progress, or maybe you're just very perceptive, tend to report things like blurry vision, fuzzy vision, difficulty recognizing familiar faces, straight lines may appear wavy, a central scotoma, or central vision loss. So in our clinics, there's a few different things that we can do to actually diagnose macular degeneration in our chair. The first, of course, is visual acuity. Visual acuity is going to, again, stay fairly stable through the first couple of stages, but should be watched very closely, especially in our intermediate and late stage macular degeneration patients, because those can change very quickly over time. A few photoreceptor changes can mean the world of difference in a patient's visual acuity, and we want to make sure that we're documenting that and following that at each visit. Second is dilation. A very thorough dilated fundoscopy exam. This is going to determine whether or not the patient needs further testing, whether we see drusen, what size they are, what stage the patient's degeneration might be in. and can be, as far as frequency, is determined based on their stage. So if they're early or if they're stage 1, probably just going to follow once a year. But if they're starting to get into the stage 3, definitely stage 4, sometimes even stage 2, you want to do that a little bit more frequently, whether it's 6 months, maybe even 3 months, depending on the case. AMSR Grid has been around for a really long time, but it is a good tool to send home with your patients. It's not the most reliable tool. Of course, we know that patients aren't great about doing it every day. They're certainly not great about doing it the way we tell them to do it, but it is better than nothing because, as we mentioned, symptoms can be blurry or wavy lines, and if they are performing their AMSR Grid at home, they should be able to pick up on that prior to coming into the office and be able to request a visit. So thorough education with your patients of how to use it, why it's important, and making sure that you're checking in with them when they come into their appointments so that you can find out if they're doing it at home and remind them of what they should be doing is really best practice there. OCT is the next commonly used diagnostic tool. It's really the first tool that we've ever had that allowed us to non-invasively stage and get a picture of what was happening underneath the tissue in a patient with macular degeneration. So we're able to visualize not only drusen and choroidal neovascularization, but a breakdown in Brooks membrane. We can see thickening due to fluid or due to neovascular membranes, and we can also see thinning due to atrophy. So we can document all of those things and really track that very specifically over time, and gives us a much more in-depth view. So I really encourage all of my colleagues that maybe doesn't have an OCT in their office to find another colleague in town that you trust and work with them, because a lot of times we forget that you can just send out for testing and it still come back to your office. Allow yourself to be the one to interpret it. You can bill that. But that way you're still getting that same disease management and care for your patients, even if you maybe don't have access to the technology there in your office. Fluorescein angiography is another test that's been out for quite a while. It was primarily and still is performed within specialist office. So usually our retinal specialists were the ones taking care of this. Basically, dye is injected into a patient's vein, and then photos are taken at prescribed intervals so that we can watch blood flow through the vessels by tracking the dye. This was a really great way of being able to track neovascular membranes and make sure that there weren't any leakage or thickening or problems through there. Watch the choriocapillaris, all of those sort of changes, but it is very invasive, and a lot of patients aren't able to tolerate the dye, or they might be allergic to the dye. So it was a little bit more of a hurdle for some patients to go through to be able to have that test, even though it did give us a lot of information. Thankfully now, though, we're actually able to do angiography through our OCTs. This technology has been available since 2014, originally in research sites, now in practices. And it actually allows us to visualize the retinal microvasculature within the patient's tissue, so in vivo, in depth, without having to use dyes and be able to track it over time. So as I said before, we previously only had fluorescein angiography and in some cases indocyanine green angiography. But this actually allows you to take those same pictures right there in your office, in vivo and in depth. Basically, the way that this works, since we don't have a dye, is that it utilizes motion contrast to detect blood flow. So we know that the structures within the retina, the retinal tissue, the vasculature are stable, they're not moving. So these images track what is moving, which is the blood, and knows that that is able to visualize blood flow through the vessels just through the motion contrast that's detected. So the strengths of OCT angiography is that it really gives us a better view of the deep capillary plexuses and choroid than its predecessors. So we don't have to use dyes, which means patients are safe and that we can repeat it as often as we need to. We also don't have any artifacts from the dye leaking. So in some cases, if patients' vessels were very damaged, or if we had fluid leaking into the retina, which is one of the main concerns with wet AMD, that leakage would actually obscure what we saw on the fluorescein angiography. In this case, we don't have to worry about that. As I said, it can be repeated as much as necessary, and it's overall a fast test for the patient. Now, that said, it takes some time for the software to actually capture that same area multiple times. So that it's a little bit of a slow process by the time that everything is saved on the clinician side. So it's easy for the patient, but sometimes it does take a little bit of processing. There's a lot of differences in hardware, software, scan sizes between the different manufacturers. So if you're looking to get an OCTA, make sure that you really look into exactly what the machine that you are considering uses and how quickly it runs and how it might run for you on your internet or your software, so that you're able to have the best practice within your offense. Just like we don't have the dye leakage obscuring our view, we also don't have the dye leakage. So that means that we don't know if those vessels are weak enough to leak. So a little bit of a plus and a minus there. We also can't provide information on transit time or vascular filling like we could with FA, or image the peripheral vasculature. So an OCTA is just going to give you that central area, whereas doing some of the wide field photography with FA actually allows for this. And it does require an in-depth understanding of interpretation. So if you ever were to decide to go get an OCTA, just make sure you take the time to really understand what you're looking at. There's lots of resources out for that now. I think we even may have some lectures going more into that throughout the weekend. So make sure that you just really dive into that so that you can get the most out of your equipment. So particularly in AMD, OCTA has been used in research to study both dry and wet forms, but clinically it's really mainly for wet. It allows for detection of the 3 types of macular neovascularization. Type 1 is neo that lies below the RPE. Type 2 is going to be between the RPE and the retina. And type 3 arises from the superficial retinal vasculature and grows downward toward the neurosensory retina and choriocapillaris. So it's almost backwards of what we normally think of when it comes to neo. We're able to pick up previously undetected non-exudative neo, which is type 1. So usually in these cases, because it's below the RPE, it's easy to miss, but OCTA actually allows us to visualize that quite easily and pick that up much faster, which means our prognosis for our patients is significantly higher due to the ability to get them the correct treatment before we would have had to wait for leakage or damage. Clinical utility for tracking neovascularization kind of remains unclear. So they're not using OCTA at this time to really track how effective the treatments are. We're still relying on FA for that at this point, but more in a diagnostic setting and getting the patient the right treatment, which is a great way to use OCTA. A couple of things to consider when you're thinking about using it with macular degeneration. Some features like drusen or geographic atrophy, macular neovascularization can affect the automatic device segmentation. So what that means is that the segment of scans has to be at a certain ratio and very smooth throughout the testing. Sometimes when we have these things appear, we're not able to get good views of the vessels. So just making sure that you assess the segmentation lines on the B-scan is necessary so that you know your interpretation is accurate. Neovascularization lesions always need to be interpreted in context of their B-scan, so you know exactly what layer they're in. Preset slabs are available on the OCTA devices, but they don't really give a great on-FOSS view of those neovascular lesions. So therefore, sometimes you need to do a manual slab so that you can actually see exactly where those vessels are in their depth. And then thirdly, reflective surfaces such as the RPE above type 1 can lead to, and drusen as well, can lead to projection of flow, which just means that it obscures your view. So again, using the B-scan assessment to make sure that you highlight that artifact will help you know if it's a false positive or if your view is obscured or if what you're seeing is real. Here's a couple of examples of OCTA used for geographic atrophy. So in the first picture, we're seeing an on-FOSS choriocapillaris angiogram with displaced choroidal vessels, which mimic well-formed vessels seen in macular degeneration. So in this case, it's actually just displaced choroidal vessels. Not so much neo that we would need to treat, but something we'd want to watch. Whereas in the second picture, or B, we do have an on-FOSS choriocapillaris structural image showing the signal intensity that we get in those same vessels due to atrophy on top of it. So in this case, again, we don't have a neovascular membrane, but we're able to see those vessels a lot more clearly because the tissue on top of it has atrophied. So it's important to know what you're looking at here, because if you didn't, you might mistake that for neovascular membrane and treat the patient incorrectly or refer the patient incorrectly. Our third picture shows a B scan of the atrophic area with an actual overlay that allows you to see choroidal flow detection and upward displacement of the vasculature. D basically shows the same thing without that overlay. So in D, you can really clearly see the choroidal hypertransmission that happens when we have atrophy. So in other words, we're imaging much deeper because we don't have tissue overlying that's obscuring our view, which in this case is a bad thing because it's atrophied away. But this waterfall appearance here is very indicative of geographic atrophy on an OCT, and especially OCTA. So let's switch gears and look at neovascularization with OCTA. As we saw before, hyperreflective is common, but that doesn't always mean that it's neo. So you really, again, need to use your B scans, make sure that you know what you're looking at. Pictures A and B go together. So this is type 1 neovascularization. The bed of vessels is below that RPE layer and often would have been missed. And you can see here that we get that hyperreflective choriocapillaris on FOSS, but then when we do the cross section, you can see exactly where that bundle lies. Our second set of images, C and D, is going to give you a shot of basically type 2. So here we're in between the RPE and the retina. This is going to show not only your vascular branching, which is very suspicious for neo, it's also going to show you the pocket between the RPE and the retina that's being affected. And then in picture E, this is type 3. So this neovascularization has actually started in the retina and is working its way downward toward the neurosensory cells. And its indicative and hallmark appearance is this white tuft that you see indicated by the white arrow in picture E. It shows that the intraretinal flow is trailing downwards and toward the choriocapillaris. So this is very difficult to see on FOSS because you only see that little white tuft. So again, pairing it with its B scan will give you a whole lot of information there so you can make your clinical decisions more accurately. Fundus autofluorescence is another area where we've made a lot of strides lately, and it's one that is very available to us in clinic. It's a non-invasive retinal imaging modality used in clinical practice to provide a density map of lipofuscin, which is the predominant ocular fluorophore in the retinal pigment epithelium. So that's a mouthful, but what it basically means is just that FAF is able to pick up on lipofuscin, which happens in a lot in macular degeneration due to the breakdown and uptake of those photoreceptor segments. These are available from multiple companies now. You can get them in ultra wide field imaging, regular fundus photography, scanning laser, ophthalmoscopes. So very wide array of options. Ultra wide field is where I see that used the most. That's what we have in our office. And it really does give you a lot of information about your patient's status just by taking pictures. So this can be used to diagnose and manage AMD, macular dystrophies, retinitis pigmentosa, white dot syndromes, and many other retinal conditions. So it's not just for AMD, quite versatile. It is non-invasive and it is easy to use. So great for your staff. They can do this quite easily, a little bit of training, and you have a very useful, easy device. So the areas of excess lipofuscin, his accumulation, are going to be hyperfluorescent. So this is going to mean that areas that are actively being broken down are hyperfluorescent. On the flip side, areas of dead or missing RPE cells are hypofluorescent, as that lipofuscin is not present anymore. This is important to remember as we're taking these pictures because this gives us an insight into where those patients may be headed. You can use green or blue light for cell excitation. It was blue originally because that was where most FAF originated. However, now green is really recommended because the blue typically is absorbed either through the retina or the xanthophyll in the actual macular area, whereas green is not. In AMD, we see an elevated lipofuscin causing increased FAF in early stages of AMD associated with drusen and RPE metabolic stress. So basically we can pick up on drusen, we can pick up on areas around geographic atrophy that might be changing and unfortunately progressing for those patients just by taking these pictures. The decreased RPE lipofuscin is associated with advanced stages of AMD, and the RPE is damaged and ultimately stops lipofuscin production. So that's why we start to see hypofluorescence there. Very helpful in identifying basal laminar drusen, which patients that have that condition have a significantly higher risk of eventual conversion to wet AMD. So basal laminar drusen is defined as drusenoid lesions that are significantly outnumbered in FAF pictures compared to what they're seeing in clinic. So you look at a patient's macula in your chair and then take a picture, and there's a whole lot more in the picture. That tends to lean toward basal laminar drusen and not a great prognosis for those patients. Classic neovascularization is going to be a focal darkening in the area of the confirmed thickening. So you can see that in both of these pictures below. Picture A has a little bit more significant focal darkening, B a little bit less, but both of those represent neovascularization in that area. And it's likely due to the position of the neovascular membrane and blockage of the natural autofluorescence. Sometimes we can get a little bit of autofluorescence, hyperfluorescence, I should say, at the bottom portion of that, and that's simply just because of gravity pulling down that, that lipofuscin. Now, in geographic atrophy, it is significantly important to take these pictures and follow these patients this way, because as we watch geographic atrophy, we know that hypofluorescent dead cells are already dead. They're not going to change. They're not going to get worse. However, if they have a hyperfluorescent area around them, that means that that patient is probably still losing cells and likely going to progress. The borders of geographic atrophy have been broken down into 5 phenotypes: none, focal, diffuse, banded, and patchy. And diffuse has been separated even further into reticular, branching, trickling, fine granular, and fine granular with peripheral punctate spots, or GPS. What that means, you can see here on this picture, is that the pattern of that hyperfluorescence is different depending on the type of borders that we have. So our diffuse and the banded are the 2 that are going to lead to more progression, and the other 3 have less progression, although focal and patchy do have some hyperfluorescence. We want to watch those patients closely, just not as worried about them as we would be with the other 2. Dark adaptation is a newer technology. The All-Star study, which was the Alabama study on early age-related macular degeneration, showed that basically patients with early macular degeneration have a slowed dark adaptation compared to age norms. So what that means is that they flashed a really bright light, and then they measured the amount of time that it takes the eye to recover from that flash. We know that with age that changes, and that's normal, but this is going to be a significantly longer amount of time for that adaptation to occur. And it gives us a really good idea of patients that may be headed toward macular degeneration, with most of the patients identified in the study developing early AMD within 3 years. So great way to get ahead of things, to educate your patients, to do preventative measures. And currently the ADAPT-DX is the main dark adaptometer that's available to patients. It's a headset technology in case you don't have room in your office, you want something that's a little bit easier, and it's very similar to a visual field. So uses age-adjusted norms to discern between the normal results and AMD, and it has a pretty high sensitivity and specificity, so you can rely on that. Artificial intelligence, basically here we're looking at whether computer programs are going to be able to interpret OCTs and do photos and that sort of thing so that they can determine staging of AMD and recommend treatment. We've had really good studies that have actually shown that this is possible in macular degeneration. So we want to make sure that we're watching that over time because it can be used for things like telescreenings, telehealth, remote screenings if you can't get to your patients. It also is going to help with research going forward. So definitely think that this will be an area in macular degeneration that we see a lot of technology coming down the pipeline in. So last but not least, we're going to quickly look at prevention and treatment. The best treatment in macular degeneration really is prevention because there isn't a great treatment available. We can't reverse the damage that's been done, unfortunately. But in dry AMD, we want to think about our supplements. So we know for everybody with macular degeneration, no smoking, watching their diet, trying to eat a diet high of antioxidants, making sure that they're getting, weight control, if they have a family history, that they're letting us know so we can track it. In dry AMD, though, we were able to look at the AREDS study in the late 90s and early 2000s, which gave us a breakdown of what exact combination really helps slow the process down. So AREDS 1 came out with vitamin C, vitamin E, beta carotene, zinc, and copper. And then in 2013, we saw AREDS 2, which looked at, do we need the beta carotene versus lutein and zeaxanthin, which wasn't available in the original study? Could we combine those two, or which was more effective? It turned out the lutein and zeaxanthin was more effective, so that is why it's in the newest formulations. Additionally, they found that beta carotene doubled the risk for former smokers of lung cancer, so it's very important that we make sure to screen our patients before we recommend supplements. They also found that omega-3s really weren't effective in AMD management, so that was not added into the formula. One interesting note is that neither AREDS 1 or 2 prevents the onset of macular degeneration, but they both reduce the progression from intermediate to advanced by about 25%. So dry AMD in the future, we're hoping, of course, that we can do more than just prevent it or slow it down. Some supplements now are adding mesozeaxanthin, which is found in the epicenter of the macula. Unfortunately, it's a little bit hard to isolate that, though, so studies are a little variable on whether or not that gives us much effect, but there are a lot of supplements that are adding it in there. And then drugs that target the immune system. So we know that the complement cascade is involved in macular degeneration. So some companies are looking at drugs that are going to actually target that cascade, stop it, and make sure that the cascade doesn't attack the retina and cause macular degeneration. And then lastly, replacing dying cells in late dry macular degeneration with stem cells. Finally, we're going to quickly look at wet macular degeneration. So the main treatment and the mainstay that we've seen for the last 15 or so years is anti-VEGF treatments or injections. These are given about every 1 to 2 months, and it helps approximately 50% of patients keep their vision. Now, in research, this was a lot higher, closer to 90%, but because of compliance and the fact that patients have to go monthly, and a lot of times these are older patients, have a hard time getting to the treatments themselves. In the general population, it's more like 50%. Photodynamic therapy has also been available as a treatment, but it's not used nearly as much as anti-VEGF. We do expect at some point that gene therapy will have a role in wet AMD. We're hoping that that will be a one and done treatment so that they get one injection and it will help the eye make its own anti-VEGF. There's 2 methods to do this. One is inject the gene therapy behind the retina surgically, and then the other is to inject it into the eye like we do with our current therapies. And then finally, multiple drugs in this area are being investigated, but unfortunately so far none have been approved. Some wet AMD treatments are actually multi-purpose drugs. So we've got a few, that one of which is kind of leading the pack here. So faricimab targets the VEGF and a protein called angiopoietin 2. So we're getting almost like in our glaucoma patients where we get combo drugs, we're getting a combo drug here. The more methods of action that we can use, the better. And so we're getting a lot more result, which means that it lasts longer and patients don't have to come back for up to 4 months with this drug. Still injected just like the current treatments. There are some researchers out there that are looking at COSOPT, which is our actual glaucoma medication, to be combined with anti-VEGF. which is going to reduce retinal fluid accumulation, and it does last longer than just VEGF by itself. And then lastly, OPT 302, which doesn't have a brand name yet, is very similar to the faricimab. It also targets the same protein, has the same combinations, and lasts longer. Lasting longer, definitely a good thing. Most patients do not enjoy month or 2 month injections. So you can see here, there are 3 drugs that are being studied there. Vovu has actually already been approved for use in the US, and 1 in 3 patients can go as long as 3 months between injections. So that's, significantly longer than they were with our current therapies. The other 2 are not quite there yet. Our molecular partners have had to go back to the drawing board. They rebought that drug from AbbVie in 2021 after it being denied in 2020. So we'll see how that goes. And then sunitinib, which is a gray bug vision drug, is in phase 2 trials. So we'll see if that gets approved, but it has a 6-month durability if it does. And then finally, we just had a new breakthrough in wet AMD management approved October 22nd of this year. So it just came out, called Susvimo, which is going to actually be an intravitreal use of an ocular implant to deliver anti-VEGF treatment. It's the first wet AMD treatment in 15 years to provide an alternative to standard of care eye injections. So it's our first real change in the last 15 years. And it allows for continuous delivery of the drug into the retina over time with as few as 2 treatments per year. We can supplement that with 0.5 milligram of intravitreal injections if needed. Very few contraindications, just ocular or periocular infections, active intraocular inflammation, hypersensitivity, few adverse reactions, conjunctival hemorrhage, which can be expected, 72%, hyperemia, 26%, iritis, and eye pain also prevalent, but overall well tolerated, especially for the benefits. So I know that was a lot to throw at you. We're certainly trailblazing in this category, and hopefully we'll have even more things to offer to our patients. But I really hope that you enjoy the rest of the conference this weekend. Thanks for joining us today, and thanks for having me.
Thank you so much for joining us, Dr. Fulmer. That was excellent. AMD is always, as we were talking about in the chat, always something that we need to be aware of, because in those more severe forms, it can be so devastating to patient central vision.
Yeah, it absolutely can.
Thank you guys for joining us on this lecture. For participating, I'm going to give you a code, very, very fitting for our topic. It's Angioplex, ANGIOPLEX, Angioplex. I'm not going to type it in the chat because I only want you guys to have access. I don't want anyone to come in later and be able to get it. I want you guys to have that code because you stay tuned with us today. If you want more codes, you should check out the exhibit hall. I'm already up to 20 raffle codes already. This free event would not be possible without our sponsors, so please take a moment to visit their booths, chat with them, and get connected. You can also check out Jessup Cellars, the official wine of eye care. At their booth, you can view their wine collection, pick up a bottle, and join us at our Q&A sessions. I invite you to sit back, relax, and take a glass of wine, and we'll see you at our next session, which is a whole new approach to treating dry eye disease.